All right, good evening, everyone. Thank you for joining us. We're excited to welcome you to tonight's webinar, How XTRAC Can Benefit Your Patients Clinically and Your Practice Financially. Tonight's webinar will run for about an hour, and we'll leave time at the end for a Q&A session, so feel free to drop your questions in the Zoom Q&A box throughout the presentation. I'm pleased to introduce you to our speaker, Dr. Michael Nazareth, Board Certified Dermatologist and President at Western New York Dermatology and longtime XTRAC provider. Dr. Nazareth will be walking through the clinical value of the XTRAC, sharing real-world insights and patient outcomes, and discussing the financial impact it can have on dermatology practice. And with that, I will turn it over to Dr. Nazareth. Dr. Nazareth, before we jump into the presentation, if you could begin with a brief introduction, your background, your practice, and your experience with the XTRAC excimer laser. Thanks.
Absolutely. Thanks, Jake. So my name is Mike Nazareth. As Jake just mentioned, I have been an XTRAC user for many years, since 2017. We are a fairly large practice in the Buffalo area with a number of providers all in one location. And we do a full range of medical, surgical, and cosmetic dermatology, treat pediatrics as well, which is a large portion actually of our practice. So this has been a very versatile device for my practice, and I'd love to show you guys how it can benefit you as well and your patients. So it's been a win-win for us in terms of our patient care and for our practice in terms of financial operations and streamlining this excellent option from a light therapy perspective. So I'm going to start here by going through psoriasis, vitiligo, atopic dermatitis, and how XTRAC can benefit your practice and your patients. So overall here, there's an introduction, there's some patient models, a clinical summary, but then we'll actually go through on the second half of this and talk about the partnership program, some of the consulting pearls before and afters, and the impact to your practice finances, and how STRATA benefits your companies as well. So XTRAC is an energy device that delivers laser energy at 308 nanometer wavelength, which is a very particular kind of UVB light energy, very focused, and the optimal wavelength to induce apoptosis of the autoimmune T cells that are the hallmark of these various disorders that it treats. It is FDA approved for the treatment of psoriasis, vitiligo, atopic dermatitis, and leukoderma. And unlike many other lasers, it is safe in all skin types, even our darkest African-American patients. So this is a very large patient base that we're talking about between psoriasis, vitiligo, and atopic dermatitis. You're talking about almost 10% of the US population technically that has these diseases. Clinically proven over many years, very safe and effective. It is covered by insurance, so there's very minimal to no financial burden on patients. And there are some copay programs that are available that I will go through. This is huge for our practice and could be for your practice too, because there's no upfront investment and no capital expenses we see with so many lasers. That has really become a concern for a lot of practices in this day and age where, technology advances so rapidly and you worry about buying a machine that might go obsolete. So not having that large capital investment is a big deal too. And then the pay-per-use model, which is, basically profitable, flexible, and completely hassle-free. There's no risk to the practice in this. STRATA really is driving the whole operation. As I mentioned here, you're basically talking almost 10% of the US population between psoriasis, which is 7.5 million adults. Obviously, there's some pediatric psoriasis as well, which we treat with this. Vitiligo, 2 to 3 million adults, and atopic dermatitis, 16.5 million adults. And again, this is not even encompassing the pediatric patients who have these three diseases, which can also really benefit from this treatment. So a large number of people can benefit from it. And many of these people are already in your practices seeing you and you're treating them with topicals and other therapies. But this adds something that you can add to those therapies to kind of kickstart the reaction and improve the patient's outcome sooner. There are dedicated CPT codes for XTRAC, which you would bill your insurance company or bill the insurance company of the patient, which are based on the surface area involved for 969202122. There's also the 96999, which is an unlisted code for certain insurances that put vitiligo under there. Recently, the CPT panel and the AMA has accepted a revision to expand the indication so it's not just psoriasis for 9692021 and 22, and that it's for these autoimmune skin diseases that are FDA covered by the excimer laser, which will streamline this process. So we're in the process of moving through that. Right now, some of my insurance providers will allow me to use these codes, whether I'm doing psoriasis, atopic dermatitis, or vitiligo. Others are requiring us to put vitiligo under the 96999. Those are things that Strata will help you with when you enter the data into the RDX portal, because they handle that prior auth and will tell you which code to bill that insurance company. So this is not something you have to worry about. Understand, however, that as we move forward with the AMA coding panels and things, that if they do accept all these streamlined things like they have and insurance companies start adopting it, it will make it much easier with just those 3 codes for all XTRAC patients. Excimer laser really is advantageous for a number of reasons. First of all, it's been clinically proven with hundreds of peer-reviewed studies as monotherapy, or more importantly, what I use, adjunct therapy. So none of our patients really are being treated in isolation only with the laser. They're also receiving topicals and other medications. Some of our psoriasis patients are on biologics. Some of our atopic patients are on biologics. Many of our vitiligo patients are also being treated by Opzelura. And other, TCIs and TCSs. It is very targeted. It's just treating the affected area and sparing healthy tissue, reducing unnecessary exposure, unlike, phototherapy boxes, which also deliver a lot less energy. So you need many, many more phototherapy treatments to get the effect of one treatment of an excimer laser treatment. And then you're obviously delivering the energy to where you need it and not where you don't. It's proven to be very effective for resistant lesion and those stubborn areas, which, maybe topicals are working well for other areas, but there's still stubborn areas you want to get to. Versatile in its application. You can use it on scalp, hands, feet, hard to reach areas. And the big one that I love for my psoriasis patients is it really works well for psoriatic nail disease, where topicals don't. Most of us are not barbaric and don't want to inject proximal nail folds with IL Kenalog. And sometimes it's not practical to necessarily jump to a biologic or a systemic medication just for nails. So we have some patients where we can treat their psoriasis just with a topical and yet get really good results in nail clearance by using our XTRAC laser. Again, as I kind of touched on, conjunctive use really is the way to go with this. You can use it with topicals and other systemic medications. Reduce medication dependence. The problem with topicals is they're very reactive, right? The patient gets a spot, they treat it. The minute they stop using the topical, tends to flare up again. This can induce periods of clearance that are much longer. It's not a cure, but as I tell my patients, it induces longer term remission in their course of disease. It's non-invasive, and that's actually very helpful because and it doesn't hurt, which is great. So we use it on our pediatric patients extensively, and the sessions are pretty quick. They can take 10 to 20 minutes. Some of the more higher surface level or surface area affected patients can take a little bit longer than that, but they're very efficient. In my practice, these are delegated treatments. A nurse does these treatments. They have a dedicated schedule for XTRAC patients. And, unlike some of my provider schedule, we can get behind some days or be running 20 or 30 minutes behind. The XTRAC schedule runs on time. So it's very respective of patients' time. So if they're coming 2 or 3 times a week to your office, it's very quick and easy for them to get in, get out at their scheduled time, and we don't run over. Now, we talked about how beneficial it was for patients, but it's also very beneficial for your practice as well, because here's a rough idea of the revenue. You can see here, these are the national averages in terms of what the reimbursement is for those 3 codes. So you can see there that the annual revenue per treatment is quite high. So if a patient gets 16 treatments, average revenue is about 155. You're getting almost $2,500 for that patient, which is significantly more than you're just getting for your 1 or 2 office visits where you're prescribing a topical medication, or worse yet, where you're prescribing a biologic and now you've got to pay that biologic coordinator, that medical assistant, or that nurse, or that provider to sit there and do all those prior authorizations. Here you're achieving this sort of revenue with Strata actually doing the work for the prior authorizations to get these approved. And you can see here, with a weekly treatment base here, if you're doing, a number of patients on XTRAC over time, if you're doing 400, 800, or 1,600 treatments, what that looks like from a gross revenue perspective. So, that 20 or 30 treatments a week, or 40 or 50, or hopefully even more than that, can really add up to significant revenue for your practice. And, I assume that all of these practices nowadays, like mine, are facing a lot of financial pressures. Our reimbursements have been cut, obviously, from a lot of, Medicare patients and things like that. Even our rates that we're getting from commercial insurers are not as good as we'd like them to be, of course. So having this as an ancillary flow of revenue really helps practices, and also obviously makes a difference to the patients too, because you're offering them another treatment that's very cost effective to them and offers very quick efficacy for these, generally difficult diseases. So you can see here the economics of this a little bit more. For patients with relatively mild disease here, you can see where that leads to in terms of an annual patient revenue. If you're looking at a biologic, moderate, severe disease, they're getting about 6 treatments a year. You're picking up about $73, $438, right? Systemics, 219 topicals in that area. But I don't want you to think of this as it's either or, because in many cases we have patients who still come for their 3 or 4, regular visits a year where we're managing their biologics, their systemics, or their topicals, but they're also getting the XTRAC laser treatment. And therefore, it's a additive revenue, not in place of. But even then, it's significantly more than you're getting from the other forms of revenue streams from just the regular E&M office visits that you're doing. So this is where Strata really took it to the next level, I think, because excimer laser is nothing new, and many doctors had excimer lasers in their offices before. But what really elevated the game here was the partnership program with Strata, because they take the work on and make this a zero risk for your practice. So practice development support is part of this with DTCs and basically helping you to develop a patient base that can benefit from XTRAC therapy. The rebate coupon is big, right? Because a lot of patients are going to have copays, and some people don't think about that because their copays are only $10 or $15. But some of my patients have $40 or $50 copays, and if you're coming 2 times a week for 8 to 10 weeks, that can add up. So the patient rebate assistance and coupon program is very big for our patients. Most of my patients do take advantage of this. They have to have a minimum of, I believe, depending on the program, about 8 treatments, and then they qualify to submit for reimbursement, so they can get that returned. Field support service, very important, right? Because if the machine goes down, you can lose thousands of dollars a day in treatments very quickly. So having a dedicated field support that's available to come out quickly and fix any issues is great. That being said, I'm very thankful that we don't need to see much of them, because these machines have been very reliable. They're not nearly as finicky as some of my cosmetic lasers that I have in the spa, where I'm very thankful I have the service agreement, because those ones tend to go down or require more service, or require fixing more frequently. Product upgrades are included in this too. So if a new laser, a new version of the machines come out, they provide that to you. You're not having to wonder like, oh, I haven't paid off the previous one. How can I afford to get the new one? That comes out. And, the newer machines that we have now compared to the one I'm using, the ones we used to use back when I started in 2016 or 2017 are much faster. So it is much more efficient. Strata covers the consumables and the parts for the machines. The DTCs that they run in various forms, social media, online, pay-per-click, various ads in magazines, TV ads, etc., drive patients to your office. So if people go to that website and you're a Strata partner, they're going to type in your zip code and notice that you have it, and they're going to send you those patients. So that leads to direct patients coming in. Those are patients who want this treatment. So it's not like you even have to sell them on the treatment. They're coming in knowing they want it. And then the biggest one, I think, is the RDX support, because it is very, very costly paying your staff to do prior auth. So by taking that burden off of your staff and giving that to Strata and letting them do the prior auths, they're then reaching out to you when the patient's approved for it and telling you which code to bill. So that makes things much, much easier for my staff. So here's some ideas of who's going to benefit from that. In psoriasis here, scalps, elbows, knees, palmoplantar, nails, ears, nape of neck. Scalp's a big one, right? Because it's a lot of pushback on patients for using topicals on those areas. So to have something that's easy to use, that doesn't leave them feeling messy and things, is great. A lot of our African-American patients don't wash their hair as frequently, right? So they don't want to use topicals that make their hair greasy or get built up or sticky or leave flakes over time, because that's what they're trying to get away from. So having that's wonderful. Inverse psoriasis, another one, those tough areas in the skin folds, sensitive body parts. You can't use strong topical steroids there. You can only use the weak ones. They don't see as much effort, tends to be, recalcitrant to therapy. This works really well for those areas. And then, those thick plaques on palms and soles. Really nice results with that. Again, we're using topicals, we're using biologics, we're using other medications, even systemics on these patients, methotrexate, Otezla, Sotyktu, etc. But having this in addition to that is great. Even up front, biologics and those oral medications don't work quickly. So sometimes that first month when you start these things, being able to get them on this therapy will help them to clear faster. Vitiligo is a tough one because our therapeutics really have lagged other diseases. We've got Opzelura, which works okay, but it's really slow. And then oftentimes you stop using that topical medication and they rebound right away. This produces longer periods of remission in these patients. You do need more treatment. I do use it concomitantly with Opzelura, but really nice results for face, neck, upper chest, and some of the fleshy areas of the trunk. Obviously, bony prominences and things on the fingers and toes not necessarily going to be as effective there. It doesn't mean we don't always try, but definitely not as going to be as efficacious as it is for face, neck, upper chest, or fleshier areas. And then for atopic dermatitis, it's really effective at improving pruritus. So, those tough areas there that you see, particularly in pediatric patients with antecubital popliteal fossa, back of the neck, wrists, ankles, things like that. Very nice to see how quickly this improves those plaques and also obviously improves their itch. So suitable for treating up to 10% body surface area. Don't limit yourself to those patients in essence, because sometimes you're going to see patients with 50, 60% body surface area, and you're going to start a systemic therapy or a biologic. But those, we know that these drugs produce PASI 90 or PASI 95 or EASI 75 or EASI 90. They're not 100%. So for those areas that are left behind, the XTRAC laser becomes a great way to clean those up from time to time. A lot of my patients, though, are at PASI 100 on their Skyrizi or their Bimzelx or something. But, I'm in Buffalo, New York. Weather gets harsh in November or something. They get a little bit of a flare up then. They get a flare in January or something. I can clean those flare ups up really nicely with this device, so I don't have to worry about switching biologics, which may be, working well for their arthritis or other conditions, and we don't want to rock that boat. Again, as I mentioned, really nice to do in conjunction with biologic medications and topicals as well. But, over time, you don't necessarily want your patients married to their topicals. They get tired of it. Compliance is low. Unlike steroids, again, no atrophy issues here. And it becomes a really good choice for patients in special situations. So pediatric patients, they don't necessarily want injections, obviously, blood draws, things like that with systemic. So having this there is a wonderful option there. Obviously, our choices for systemic medications are more limited in pediatric patients too. And we really don't have a lot of options for severely immunocompromised patients, transplant patients, pregnant or lactating women. Some of our patients who have a recent history are actively being treated for solid organ malignancies. This becomes a wonderful option because we can safely treat all of those patients without any risk. Overall here, keep in mind that if you have generalized disease or erythroderma, photosensitivity disorders, or really can't commit to multiple treatments a week, this might not be ideal. It's not ideal for all of our patients. I have patients who drive from northern Pennsylvania. They're 2 hours away. This is not practical to have them drive back and forth from my office that far away. Anybody who's got that history of lupus or a photosensitivity disorder, again, I'm steering clear of that. Erythrodermic psoriasis and generalized disease, though, sometimes they get really good with the biologic, and then I'll use this after the fact just to clean up a couple of areas. Again, this is not my first line treatment for those diseases. I touched on this earlier, kind of why 308 nanometer wavelength was so ideal, but basically it's a very high intensity narrowband UVB source, which is an optimal area to cause T cell apoptosis in psoriasis, vitiligo, and atopic dermatitis. And you can see here why that's so effective. It's just that one wavelength there. So now kind of honing down here to psoriasis, it's very, very efficacious for psoriasis, approximately 95% clearance in just 10 treatments. At least 75% clearance was observed in an average of 6.2 treatments. And this is a long-term improvement because patients remain clear after a year. So unlike topicals where if you use it and then you stop using it, they tend to flare up, this leads to longer periods of remission. It is effective in treating thick, scaly plaques on knees, elbows, and scalps. Inverse psoriasis responds very well to this. I did mention earlier nail disease is another one that I particularly like it for. And then it is also effective in localized pustular psoriasis as well. So we've actually had patients where we even used Spavigo and had most areas clear with a few leftover areas where we've actually used this as well. Spavigo is that new IL-36 inhibitor, which incidentally now has a sub-Q form that we've used successfully as well. This is a great picture. I love this. This is a before treatment and after treatment of a scalp psoriasis patient. You can see just how thick that scaling is there. And after just 9 treatments. So basically for somebody who's coming, twice a week in cases, 1 month later, just using this machine, we're able to get really, really nice clearance on that. So 95% clearance of scalp psoriasis, an average of 21 treatments. Clearly, this was a much bigger improvement in just 9 treatments. Improvement, they say as early as week 4. We've sometimes seen that a little bit sooner. Clearly, they're not clear by then, but patients are noticing that decrease in itch and some of the thickness of the plaques even earlier than week 4. 96% of patients overall do respond to this. Reduction in itching, discomfort, scaling, redness, and sustained relief 6 months plus post-treatment. So when patients are clear, like that patient there who's clear after 9 treatments, they're going to tend to stay clear over time. And again, you can use it in combination with topicals or biologics or systemics. Vitiligo, a little bit trickier here, obviously. These patients need more treatments, and there are no good systemic treatments, obviously, for vitiligo. Over 75% of repigmentation is achieved in a significant portion of patients. Visible repigmentation can be achieved in just 15 treatments. Best outcome areas, face, neck, upper chest, where you're getting about a 90% response rate. You're not going to see as much on some of those bony prominences like elbows, knees, fingers, toes, top of the foot, etc. And a very durable repigmentation because there's no pigment loss that tends to happen in the follow-up period. So, if you can get this result, patients tend to hang on to their pigment. That's not to say they can't ever flare again, but in general, once they have the pigment back, it tends to stay there. And high success rates in treating patients or treating lesions that are less than 3 years old. We do treat patients of all ages with this too, including our pediatric patients too. So you can see atopic dermatitis here, 81% reduction in itching within 4 weeks. 85% are getting complete remission after just 10 treatments. Major improvements in erythema, inflammation, skin thickening, and itch. And greater improvement compared to a topical steroid at 6-month follow-up. Part of that's also obviously the fact that you're getting these long periods of remission, so you're not married to that treatment. That's the problem with topical steroids. Patients use them up front, they get tired of them, and the minute they stop using it or back off on treating, atopic tends to flare. Again, unlike topical steroids, we don't have to worry about atrophy or dyspigmentation, which can result for that, which can be very troubling for patients who are skin of color patients. So this becomes a nice option for them because it's safe and doesn't produce the hypopigmentation that we see with some of the topical steroids, particularly on the face, which can be very troubling. And up to 26 months of disease-free remission with no relapses has been seen in atopic, which is great because, we can't go probably a few weeks without a flare-up in terms of a topical medication where you can get up to 2 years of disease-free remission with the XTRAC laser. So minimal side effects here. Blistering is normal. And I think that's important to tell patients. If you're using a high energy device like a laser, you can get blistering. We have a few patients who get a little bit more than they expect, a little bit uncomfortable from that. We'll give them a little mupirocin or have them use some Vaseline on it. Maybe skip the second treatment that week until they get back down and then continue from there. Setting that expectation that they can blister is good to do so they know that this is nothing scary. And honestly, patients who blister often get faster clearance and get to those endpoints that you're looking for sooner. Hyperpigmentation or post-inflammatory hyperpigmentation is also normal from the treatment, will fade over time. It is safe for use in children, pregnant, and lactating women. It requires a lower cumulative dose compared to other phototherapies because it is so concentrated and you're just treating the affected area and not the unaffected area. And the most important one, which is important to review with cancer, because if you're telling them that it's a wavelength of UVB, a lot of them will think, this can increase my risk of skin cancer. So I'm very wary of this, but it does not increase the risk of skin cancer because it's such a focused beam of just that one wavelength in a targeted area. So the partnership program, I touched on this before. Again, it all starts with getting that patient into your office. Many of these patients are in your office, right? So you don't necessarily have to create new patients. In many cases, you can actually just be adding this to the regimen of patients that you're already treating for psoriasis, atopic dermatitis, or vitiligo. The RDX support is wonderful in terms of getting these patients into the system to get the prior auth approved. But overall, it's very important for your practice to leverage all of these assets that Strata provides. I think that a lot of practices that I've talked to before sometimes don't get the maximum benefit out of the machine because they're just not getting enough patients into it and not really making full use of the device being there. And other ones probably could get better results. They're taking the trouble of putting it into RDX, they're getting the patient approved, but they forget that there's that patient assistance program with those rebates. So sometimes patients are approved for the therapy, but then think, oh, I can't afford the $40 or $50 copay, so I'm just not going to come in for it and make excuses why I don't want it. But they just need to be reminded that that rebate program is there as well. So take advantage of that. Strata will train, obviously every state's rules are different. In New York State, where I am, a nurse can administer this treatment. During the pandemic and after, we had some turnover in our nurses. So Strata was wonderful about coming in and training our new staff to get them up to speed so there was no lag in keeping patients on therapy. So leverage these assets because that's really what makes XTRAC so successful. So just what happens if you get a DTC call here? If a patient has reached out to your office because of a direct-to-consumer campaign that Strata and XTRAC is doing, make sure you try and get that patient in within 2 weeks. Because if you wait a long time after the initial call, there's definitely a chance that the patient's not going to follow up and kind of falls out. You really want to strike when the iron's hot. If the patient's calling your office because they're interested in XTRAC, try and get them in within 2 weeks for a consultation with an MD, an NP, a PA, somebody there who can say, yes, we want you to start XTRAC. You are a good candidate for it. Maybe you're also prescribing them topicals and other things at that visit too. It doesn't have to be exclusive just to XTRAC. In many cases, if they've been severe, I'm also doing a systemic. Plus, I'm putting in the information into RDX to get them approved for XTRAC as well. Start that first XTRAC treatment. Usually that's going to occur within 2 weeks because most patients are getting approved pretty quickly on this. And obviously, Strata has people dedicated to getting these prior auths approved. So they're faster than my own office in many cases of getting prior auths. Prior auths for biologics are time consuming and take longer. Usually they're denied and then you're fighting the denial. This goes through quickly and they're doing the work for you. So they're going to log into the portal. My nurses see that it's approved. They call the patient, get them right on that schedule and get that first treatment done. And then I have them go ahead and schedule subsequent treatments right away. You don't want to treat this like normal office visits. You really want them to commit to that 8 to 10 treatments right up front. So get those appointments scheduled at the first visit. This way they're on the books. You don't have trouble saying, oh, that schedule filled. That's a time slot you wanted. And now the patient can't get treated for 2 or 3 weeks. You lose momentum and you don't get the efficacy that you want. So book those 8 to 10 treatments right up front. I have my nurses book it right at that first visit. So that this way they're in the system and they're guaranteed to have those appointments, and it encourages compliance right away. Most of my patients put it in their phone so they have the reminder there and they're ready to go. In addition to Strata doing DTCs, you can actually get some, promotional material into your office, included in your email blast and things like that. I send out an email to my patients once a month. So, for when we had, Psoriasis Awareness Month or things like that, when vitiligo is big and things like that, atopic at the beginning of the winter time, we send this out just, hey, remember we offer this treatment in my office. This is something you can benefit from. We do have the patient brochures, so my providers can hand that to the patient. Sometimes it's actually not even the patient that's in the room. We've seen parents where they have a kid, we know they have atopic dermatitis. They're like, oh yeah, my kid's flaring. We're using the steroids. I'm afraid to use the steroids. We give the parent that brochure, hey, there's this treatment we can offer your kid. So, bring them back in. Let's reassess that. Digital branded assets are there that you can link to your web page and social media platforms. And then there's also the ability to do co-op advertising. There's mailers and postcards, and we've done other things like that before with some of our radio things and billboards, et cetera, too. So leverage those assets because that helps to build your Strata XTRAC base in your office of patients who are coming in regularly, which they benefit from it, and you have that revenue stream. The reimbursement team handles the complexities of insurance coverage, which saves a lot of staff time and obviously practice funds, right? Because it costs a lot of money to pay these people to do all those prior auths. So they're getting these things turned around a lot faster, generally, 3 to 5 days, 14 business days for follow up on some of the prior auth status. But generally, a lot of times these things are turned around within the week, and then you can get these patients scheduled. So get that information loaded into the RDX portal so that Strata's people can get to work and get these treatments approved by the insurance companies. And remember, they will tell you what code to bill. If it's like vitiligo or atopic, if you're using the 969202122, or if you need to use that 96999. The rebate program, again, really improves patient compliance because if you've gone through all the trouble to talk up a treatment, patients have bought into it, they want it, they get approved. RDX system lets you know to go ahead and schedule, and the patient's afraid of the copay. So this is wonderful. By providing this financial benefit to patients, they can really help defray some of the costs of the therapy with their copays. So make sure you take advantage of that. If the machine goes down, call right away. You have your rep, of course, too, but open a service ticket and they will get out there quickly to repair the machine. Because think about it, they want you churning through those codes because that's the only way Strata gets paid, right? So you get paid when those patients are coming in. You don't want to have to cancel appointments. It does interrupt therapy. So it's important to get that machine fixed quickly. This does happen very, very quickly. We see very quick turnaround time within a few days so that we're not down and patients aren't missing more than one treatment in their cycle. So just overall, the consulting pros here, recommend XTRAC laser, and bring it up to patients who have psoriasis, vitiligo, and atopic derm. There doesn't have to be like one ideal model that you're thinking about. I look at it in all cases, right? Because sometimes it's the very mild patient where this plus a topical is enough to treat them. And sometimes it's the very severe patient where I've got multiple prescriptions, including biologic medications, where I use this to clean it up. Give them the relevant information they need. The brochures are great. Make sure they're aware of the rebate program. Submit the information into RDX so that Strata can get the prior auth approved. And as soon as that is approved, schedule that first treatment quickly. And then as part of that, remember, have that nurse who's doing the treatment schedule the next 8 to 10 treatments so they're ready to go. You don't want to lose momentum at that point. Talking points here. It's painless, it's safe, it's highly effective. There is no downtime. Some blistering is normal, but it's not so severe that they have any downtime from it. 2 to 3 treatments a week. Most of my patients are coming in twice a week for this. It is really good coverage by insurance, particularly for psoriasis and atopic. Vitiligo has been a struggle more in the past, though lately we've had more success in getting that covered. I anticipate as we narrow those codes just for XTRAC, so 9692021 and 22, for all of XTRAC and excimer laser, that we'll see enhanced coverage for that. It works alongside other treatments really well, including topicals and biologics. It targets the affected areas, doesn't treat the healthy skin, and it's offering a much more focused therapy in those areas, so you get more efficacy sooner compared to light therapy. Safe for children, pregnant, breastfeeding women, and all skin types. So overall here, about 6 to 10 treatments for psoriasis to get clear there. 10 to 20 for full clearance, depending on severity. Obviously, it works really well for those tough inverse psoriasis cases, scalp psoriasis, nail psoriasis. Results last 4 to 6 months, sometimes longer. For vitiligo, really great for face, neck, and those really noticeable areas. Facial disease in our skin of color patients can be really debilitating. So we've never had a treatment that was as efficacious as this. Even Opzelura, while it works well, is very slow. And the minute you stop using it, they tend to flare. This produces those long periods of disease-free remission for those vitiligo patients. As far as atopic goes, about 4 weeks here to see significant itch relief, sometimes even sooner. 1 to 2 weeks, we'll see a notable reduction in redness and skin thickening. So overview here, it's I'm not going to go too much into the weeds in terms of the actual dosing, but at the end of the day, use the protocols, and Strata will teach your nurses these protocols. It's important to increase the dose accordingly, because if you stay at the same or you undertreat, it's going to take more treatments to get to efficacy. So escalate the dose appropriately is what I always tell patients and my nurses, and you will see good effects where you get major success without needing an excessive number of treatments. 2 to 3 treatments a week, and make sure you wait at least 1 day in between each treatment. You can see here the vitiligo starting doses a little bit different depending on the area there. And if you're getting a moderate to good effect with tenderness, with or without some mild erythema lasting there, you can continue that equal dose. If you're not getting as much effect, again, you're going to be increasing that dose. So it is normal to see some blistering too. So I do warn patients of that as well. Atopic, same type of thing here. A little bit easier. There's only 2 starting doses here, whether you're skin type 1 to 3 or 4 to 6, where you're starting with that. And then the protocols there for increasing or decreasing the dose on subsequent therapies. Post-treatment instructions, you can hand this to patients. They can kind of keep track if they get the redness, the blisters, and things like that. After the first treatment, we give them the handout. Understand that they should schedule those 10 treatments. Treat the skin normally as they would. They can shower, apply their medications, creams, lotions, etc. freely. I make sure that they're not applying that right before they come in, because we're not trying to treat skin that's just been treated by a cream or something, but they can use it that night. They should not stop any current medications, whether that's related to their skin or not. They can continue everything. Make sure that they're watching out for sun at this time of the year, because you are delivering an energy-based device to the sun. You can treat them even if they're tan, but you don't want them leaving your office after you just gave them a light therapy and then have them going out into the sun. So if they are going to be out there, because I had one patient that we treated today, and it's finally sunny in Buffalo, they were going to their kids' baseball game tonight. So I told them just either cover that area up or treat it with some sunscreen to protect it. And then encourage the patient to monitor and record the duration of erythema and tenderness if they experience that, or blisters. And that is everything I have for you. I'd be happy to take questions on this now that you guys may have. So I'd open it up to that.
Yeah, thank you, Dr. Nazareth. That was incredibly insightful. Like you said, we'd like to open up for questions. If you haven't already, please feel free to submit your questions in the Q&A feature below, and Dr. Nazareth will answer them for you. We've got a few questions coming in. So, Dr. Nazareth, I'll go ahead and read some of these to you, but
Please.
How do you determine XTRAC is the right modality with so many options for psoriasis patients?
I tend to look at this as a conjunctive therapy. We have very few patients, maybe just a few of our peds patients and things, where it's being used in isolation. But for the most part, this is going along with it. So every patient that we see is a consideration for it. It's not going to be right for everybody. If they have generalized disease or they live far away, some patients have trouble with mobility too. They may live close, but if they're in a wheelchair, can't get transportation, things like that. You got to take into the gestalt of the whole situation there. But every patient really is a candidate for it. You may debate which biologic to use, or if you're a Sotyktu person or an Otezla person, or if you want to go with a Zoryve or a Vitama or something like that. But at the end of the day, you can use any of those treatments along with XTRAC at the same time. So there's many patients, we mentioned this, not everybody wants it right away, and that's okay. I do like to mention it though, because sometimes we'll have mentioned this to them. Their disease isn't too bad right now, particularly if I'm seeing a psoriasis patient at this time of the year. Elbow, knee, they're not too bad. And then, they have that brochure, they thought about it, right? At least they heard it. So I might not be seeing them for 6 months. November rolls around. I'm being optimistic with Buffalo. It's more like October when we get snow. But that first snowstorm hits, their scalp starts to get scaly. They get a flare up and they remember, like, oh, wait, or they've seen it in my email blast that they're getting once a month or something, like, oh, yeah, they offer that laser thing. They call the practice. They say, hey, I'm getting some flare up here. They come back in. We say, yes, absolutely. We can pursue this, put their information into RDX, get them approved, start the treatment. So we're not replacing their therapy. They still have their topicals or whatever. Many of them still have their biologics and things like that. But we're able to add this on either up front, where we need to clean things up before those medications become effective for flare-ups, or even a patient who's doing very well. Remember, most of our biologics, whether it's atopic or psoriasis, are getting people to around 90, 95% clear. Very rarely 100% clear. So it's nice to have this there to clean up those recalcitrant areas. And then quickly on vitiligo, there really is no good treatment, right? We've got Opzelura, we use topical calcineurin inhibitors, we use topical steroids. There is no treatment yet that's a systemic treatment that can give you these, long periods of remission or work as quickly for facial vitiligo as XTRAC can. So that combination of Opzelura and XTRAC laser has really been the foundation of all of my vitiligo management plans.
Appreciate that. Another question, can you walk through your treatment protocol when you're using XTRAC conjunctively with biologics for psoriasis patients?
Yeah, so in a lot of cases, it's a stepwise thing, right? Not everybody who comes in needs a biologic right away. Sometimes we're doing, methotrexate or a systemic first. Sometimes these are people who have fairly mild disease. We're only doing a topical, and then their disease gets worse. So now when I'm coming in, I'm like, wow, yeah, your psoriasis has gotten a lot worse. We need to do a biologic. So what happens? You're submitting that prior auth for the biologic. Or you may choose, like, they're so bad you want to start them right away and you give them a sample today. Well, even if I inject them with a sample of biologic today, and I don't have my TB and Hep B and Hep C back, but even then, you're still going to wait 3, 4, 5, 6 weeks before you're getting significant efficacy from that biologic. So at the flip side of the coin here, I can enter their info into RDX, get that approved within a week, and start therapy right away. And as you notice, for the two big ones here with psoriasis and atopic derm, I do the same thing for my Dupixent patients as well too. It's great to have this on board because having, with my atopic patients, palms and soles tends to be very itchy if they have a lot of dyshydrotic eczema. With my psoriasis patients, if their scalp and things like that, it's very, very troubling for them, or hands or feet. And oftentimes those areas that are the most vexing for patients are the ones that take the longest to clear with biologics, right? So I start that Skyrizi script, and yeah, their elbows and knees and back and legs are clearing really quickly, but their hands are not clearing fast. So I don't waste the appointment. At that appointment where I'm filling out the enrollment paperwork for the biologic, I am also mentioning that and getting their permission to put the information into RDX to get it approved. So now, not 100% of patients are going to follow through with that, but I will say the vast majority of my patients will come in and get a few treatments and get that done because they're very happy to get that clear before the biologic kicks in. Now, great, some of the patients do great on biologics and then they don't have to continue the extract. But guess what? Then winter rolls around, they're not 100% clear. They remember how well that worked for them before, and then boom, we do that. Another scenario is they're clear and something happens in their life, stressful event, right? Med students studying for step exams, attorneys studying for a bar exam, loss of a job, breakup of a relationship, all those big stressors, or big illness, right? People get the flu or something like that, immune system revs up, they get a flare up of their psoriasis, they call. Generally speaking, the one thing I didn't mention here is, generally speaking, when you get that approval, it's for a year. So, if this gets approved in March, April, even at this time of the year, they may be cleared up on their biologic. If they flare in October, November, or, June with their exams or something like that, you can bring them in and do a few treatments then. It's not like you have to, oh, we haven't seen you in like 6 weeks or something, so we have to re-auth it. Generally, those auths are good for a year. So keep that in mind because there are patients we see sometimes in January and February to get them clear. They do great all summer, and I don't see that patient back again till like November or December when they may get a little flare up again.
Thank you. How do you motivate patients to keep coming back to the office for treatment 2 times per week?
I think a lot of that coaching and yay rah stuff is needed in the first couple of treatments. And generally after that, it becomes a self-promoting device, right? Because patients, when they notice less itch or clearance of their lesions, are very motivated to continue. Some of them who were coming once a week due to logistics and, being able to get into the office will then increase to twice a week because they realize, like, wow, this is really working. I want to get there faster. So it's just really those first couple of weeks on that you've got to get them to commit. And, before and after pictures are great. Expectations of what they can see. Just telling them, really try and commit to that 8 to 10 treatments because by then everybody's really seeing the result. Honestly, for me, the hardest ones to really work up front are the vitiligo patients, right? Because those ones are not going to have massive results in 3 or 4 weeks. They're going to take a little bit longer. But what you see with facial vitiligo, usually by the time you've done 15 or so treatments, they're seeing results on their face. It might not be everywhere, but at least their face, which is usually the one that bothers them the most. So if you can get them to hang in there a little longer, that's important. Nowadays, it's honestly not super hard to do that simply because there are no good treatments for vitiligo. So, this may change down the road if there are systemics for vitiligo that get FDA approved. But right now, we don't have those. So that's one though where a little bit more coaching on commitment, I think, is important. because those patients are not going to see results in the first 6 treatments, right? They're going to take longer. So keep coaching them, show them some pictures. My nurses, I will say, a lot of this starts with the provider to really sell the treatment initially, but then the compliance comes from the nurses. And I will give my nurses a lot of credit. They're really personable. The one kid who walks in here now, she was terrified of this at first because she thought it was going to hurt, and wearing the goggles and stuff really scared her. Now she runs past my staff and she knows where the room is. So she's bolting past people. She's chatting up people in the waiting room. She's running out of the room to go grab a sticker. So they really get invested in the treatment because they see the result.
This next question kind of builds off that, but have you been combining topicals like JAK inhibitors like Opzelura with the XTRAC for vitiligo patients?
Yeah, I can honestly say I don't know if we have a single XTRAC vitiligo patients that's not on a topical. There's been a few where we haven't been able to successfully get Opzelura approved. Obviously, we all know the struggles with that. Some insurance companies consider it cosmetic and aren't approving Opzelura, but we have them on a TCI then. So I don't think I have any patients who are on XTRAC solely. For vitiligo, we also have the topicals going. Again, I don't have them put it on right before their visit, but they can continue that night. So this does not interfere with that treatment whatsoever.
Okay. Any guidance on steps to get insurance to cover XTRAC for atopic dermatitis?
It's been a little bit hit or miss in our area. I will say that how you document this is important. If they are already on other topical therapies that they failed, that helps, and you documenting that carefully. Documenting impact on quality of life can help too. Obviously, if there's you're wanting to use your extract laser to clear up their hands and feet. One person I have is a cook. So it's very difficult for them if their hands are inflamed to chop vegetables or to do things like that. So being able to document those things help. I will say the RDX portal and STRATA is really good at helping you with this process. This is not the burden of this generally doesn't fall on your own teams. I feel like I do a lot more of this, very careful note curation and things like that with biologic approvals than I have to do with extract. So again, it's not a independent treatment for all these patients for the most part, especially my atopics. I don't have a single atopic patient in my practice who's just getting extract. They all have topicals. Many of them are on Dupixent or other systemics too. But by building on that, that really helps. And, in many cases, it leads to less visits and things down the road too, because if they're doing well, they're not flaring up. They're not going to, urgent cares for infusions of steroids if they're doing badly. They're not, making extra appointments at my office because of that. So there are benefits to insurance companies too, in terms of streamlining care, because if they do well with 10 to 12 treatments and get under control, then they're not, soaking up more healthcare dollars later.
After how many treatments should the excimer laser be discontinued if no improvement with vitiligo or psoriasis?
So psoriasis, I'm expecting to see results usually by 10. I would give it at least, 12 to 15, depending on what it is too. Obviously, certain areas can be thicker or more recalcitrant. Palms and soles, obviously, are the ones that patients really are concerned about generally too. So, I try and give it a good 12, 15 treatments. By then, though, it's usually, I would say expect to see results by, 6 or so, but I usually give it at least 10 for there. Vitiligo, you do have to commit longer. That is a known fact, and I do counsel patients on that. I'm looking for at least 20 to 25 treatments there to see something before I would, entertain discontinuation or taking a break from it or something like that. But again, we really haven't run into patients who didn't respond at all. Clearly, some people respond better than others, and some patients have been, less than happy if they don't get a complete response. So, be very reasonable in the expectations. It's not a cure, and patients can flare up again. So, set a reasonable expectation. I really haven't had patients who discontinued the treatment because they were upset that it didn't get them any efficacy. And in general, we haven't run into this situation where we've done lots of treatments and we've discontinued because they never got a result. But remember, area matters. If you have a vitiligo patient that wants to do extract because they have a lot of hand and foot and knee and elbow involvement, they're not really a good candidate. Am I willing to try if their insurance covers it? Yes. I'm willing to do that, but be realistic. We've had some patients who did get responses. I had one patient who actually got most of their hand pigment back, even though their knee and their elbow didn't come back, and they were happy with that, right? Because it's very visible if they shake hands with somebody or something like that. It was not nearly as a complete result as we would see with the face, and it did take about 30 treatments. So set that reasonable expectation with vitiligo patients that it's going to take longer.
Does it work for nail psoriasis?
Beautifully. This has been a godsend in my practice for nail disease, to be quite honest, because we were doing methotrexate or biologics for this. I am not a personal, I know everybody's got their own opinions, so I don't want to step on toes, but I am not a personal believer of doing intralesional Kenalog to nail beds. I don't want to cause atrophy there, and I find that it's exquisitely painful for patients. This works far better than that, doesn't have any side effects, and has saved patients from treatment with biologic and methotrexate who don't otherwise need a systemic treatment because they may have some just very limited elbow and knee disease or scalp or something like that. And I can just use XTRAC to clean up those areas. And then I don't need to go to a systemic treatment. We started using this extensively during the pandemic, of course, particularly for those patients, because patients did not want to be on systemic immunosuppressants during a pandemic. And many, many people is where we did nail disease for that and saw amazing results. And now, really, anybody with nail psoriasis in our practice, we try and get them to start XTRAC because it makes such a difference to their nails.
Great. See one more question. So just a reminder, if you have questions, go ahead and plug it into the chat. But last question I'm seeing is, do you taper your patients off of laser treatments?
Yeah. So, if somebody's totally clear, and this happens a lot, thankfully, with psoriasis and atopic and even vitiligo too, we see some really nice responses on face there. Once they're clear, we kind of back down. Maybe they'll come once a week for a couple weeks or something like that until those areas are really locked down. And then we'll stop treatment. Because what's the worst that happens? If they do get a little bit of flare up, I can always reinstate it and clean it up again, but I'm not going to do unnecessary treatment. So once they're clear, within probably that week or a week and a half, because we're talking within 2 to 3 treatments, we're stopping at that point. Many times what you'll see is you're starting at a 9.6, 9.22 because that surface area is very high. And then after a few treatments, they're down to a 2.1 because you're not treating as much surface area. Then they're down to a 2.0 because now they have very minimal disease left. And then you're stopping treatment. The nice thing with this, though, is, and to me, this is a big selling point for patients. Unlike topicals, you do get longer periods of disease-free remission. And I use it that way because I do not use the word cure. It is not a cure, but disease-free remission. We have people who got repigmentation of their facial vitiligo now back in 2017 and 2018 when we first started doing this, who have not had flare-ups on their face again. So it's still not a cure. It could come back, but it does induce long periods of remission.
Thank you for that. I think that's all the questions I'm seeing. So, Dr. Nazareth, thank you again to everyone that joined. Thanks for joining us. We hope this session gave you guys a helpful look at the XTRAC can not only improve clinical outcomes for your patients, but also create meaningful impact within your practice. And now STRATA is there to partner with you along the way. So if you have any additional questions or would like to learn more, please don't hesitate to reach out to your territory manager. They'd be more than happy to help take you the next steps with the XTRAC. Thank you guys all again. Have a great night.